All right. Hello, everyone. Hopefully you can hear me. I want to welcome you all to our first part of our two-part webinar series around coding and documentation strategies. My name is Philip, and I serve as the specialist of Health Center Operations Training here at NAC. And I want to thank you all again for joining us. And the first things we want to start off doing is just reminding you all of NAC's mission, founded in 1971 to promote efficient, high-quality, comprehensive healthcare that is accessible, culturally and linguistically competent, community-directed, and patient-centered for all. And of course, that work could not be made possible without you all and your support and the work that you do in your health centers every day. Before we get started, I just wanted to remind you all of some of the upcoming operations training events that we have going on. So if you can hear me, you are in part one of the two-part coding and documentation series. And I just wanted to remind you all of the part two that's going to be happening next week on treating substance abuse and opioid use disorders via medication-assisted treatment. So if you haven't done so, we'll make sure to plug in the link in the chat box if you'd like to go ahead and take advantage of that as well. In addition, we're also offering the Practical Art of Health Center Operations, and this year it will be a virtual training. If anyone has previously attended one of these events in person, you know that these trainings are specifically delivered and tied for our operations folks. So really looking at strategies, techniques, and best practices to enhance your health center operations. So you will see a link in your chat as well for that, if you want to click on that to learn more after the webinar is completed. And lastly, just wanted to remind you all that you can find all of our COVID-19 related materials at nac.org/coronavirus. We also have growing online Nautopod community where we have PCAs, ACCNs, lookalikes, and health centers really join and collaborate amongst one another in sharing some best practices, sharing resources. So if you are not a part of that yet and you would be interested, feel free to contact Susan Hanson as you see at the bottom of the slide. And lastly, if you have any questions today throughout our presentation, we currently have 250 plus folks joining us. So I want to thank you all again for joining. But please make sure you direct your questions to the Q&A box. This is going to ensure that your questions don't get clouded or fogged up in the chat box, and we'll make sure to get a specific answer for you if you can put them in the Q&A box. And I just saw a question there. We will make sure to send a copy of the slides at the end of today's presentation, so you will receive a copy. So let's dive into it. So today we are going to be looking at evaluation and management changes for community health reporting, including face-to-face and virtual E&M visits. So I'm definitely glad to introduce our presenter that we have here. If you have been a part of a previous NAC coding and documentation series, you will know who we're talking about, Gary Lucas from ARC Pro Coding. And with this, we're going to be looking at how you can apply some of the 2021 updated E&M guidelines for your office. And then also you can learn more about how you can train up your clinical colleagues on how to code correctly and when to utilize the revised 2021 definition of the time versus when to use the updated definition of medical decision-making for coding and billing. And lastly, looking at how you can understand and when to report CBT and HCPCS codes for non-face-to-face visits, such as CMS covered telehealth, virtual communication services, and online E&M services. So I want to go ahead and hand things over to Gary to get us started today. I'm passing you the ball now, Gary, and you are unmuted. No worries.
All right, everybody, if you bear with me just a moment, let me go ahead and get my slides up. I'd like to take this opportunity to thank NAC and Philip and his team, Brandon and Olivia, for making sure everything runs smoothly today. And as always, we're deeply appreciative of the opportunity to help serve the nation's community health centers. My name is Gary Lucas. I serve as Vice President of Education for ARC Pro Coding. I will provide my email at the end of this session. excuse me, if there are any questions that you may have after the session, or if you're looking for any individual training or questions that just maybe didn't pop up until we get done with the call today. So Philip did mention the slides will be presented, and please feel free to use those internally in your office to help educate those who are not able to join us today. So for those of you that knew us as our much longer name, the Association for Rural and Community Health Professional Coding, we've rebranded because that was a heck of a long name. We were the ARHPC for rural, and then we had the ACHPC for community. And it only took us about 10 years to figure out that ARCH was Association for Rural and Community Health. Folks, I've spent 26 years of my life traveling to 46 different states, and I've taught about 1,800 workshops, and I'm proud to be associated with Arts Pro Coding for the past, 8 or 9 years, where all we do is provide documentation, coding, and billing training for rural health clinics and federally qualified health centers. Obviously, we'll use FQHCs and community health. We use those terms interchangeably. So there are a couple little disclosures and disclaimers here, but of particular notice, folks, I would ask that you pay particular attention to this second one, because the primary resources that you need in order to continue your education following this session is going to come directly from your CPT. Now, I know my video camera there is a little bit on the small side, but you know, there's a lot of software out there, a lot of shortcuts that you may be using when you're completing an encounter form or a super bill. We know that you've moved likely from a paper encounter form to an electronic version, where sometimes the providers who are making their code selections don't even get the full definition of the codes, which clearly makes it difficult to match the coding and billing to the existing documentation. But of particular importance is that the AMA is the only place where the rules and guidelines and regulations are listed as it relates to coding. Now, remember, please, there's not one word in the CPT that has anything to do with billing, money, or insurance. When we make that leap to talk about billing, we're going to have different billing rules for Medicare than we may have for Medicaid, maybe different than Medicare Advantage plans, and of course, the individual terms of your participation contracts with your commercial insurance companies really drives how we need to be matching our billing up. But coding doesn't change based on the patient's insurance. Coding doesn't change based on the patient's ability to pay, but you better believe it, the billing will be different based upon insurance. So I need to cover both of these items, and that is number one, if you're looking at what are the documentation rules that are going to drive the changes in 2021, we have to balance the notes that we find in the American Medical Association's version of the CPT with CMS's billing guidance, with a comparison or a contrast between commercial insurance. Well, interestingly enough, we've been running basically two different sets of evaluation and management documentation guidelines going back to 1992. And for those of you that are familiar with the what are called the 1995 and the 1998 Medicare updates or clarifications regarding evaluation management documentation, you saw that they were different and have been different since these codes and these new concepts were created back in 1992. Now, as of 2 weeks or 3 weeks ago there, we now have a unified message where the AMA and Medicare are both adopting and confirming the E&M guidelines are going to be the same. But if you happen to buy your CPTs from somebody else other than the AMA, you will not have the same notes that precede the E&M section. You will not have the little sentences and paragraphs that sometimes appear in between codes. So please make sure that you do access the AMA's version of the CPT. We recommend the professional version. But I guess the key issue is that we are hopefully going to simplify some of the E&M guidelines and we'll talk about the difference in coding and billing for face-to-face visits versus some of the virtual communication services or telehealth options. But the idea here is that there has, or was, I should say, a very big effort in the, well, I guess it's still the current presidential administration to issue and dictate new guidelines under what's called the Patients Over Paperwork Initiative to reduce this feeling that providers have had that they have to fill up their notes with a bunch of content in order to get to a proper code or in order to get to a higher level code. So I hope that some of the rules and guidelines you've been hearing about are positive and that you present them as being positive to your providers. As always, because there are changes that are existing here, we're going to ask you to be on the lookout for updates that may be coming in the Medicare Policy Manual, Chapter 13, the Benefits Policy Manual, and the Chapter 9 of the CMS Claims Processing Manual. And let's see, I'm probably going to have about 6 or 7 different actually probably more than that. There's probably close to a dozen different hyperlinks in this presentation, and you'll notice that the last time CMS updated the Benefit Policy Manual was in 2019. The last update that we got here in Chapter 9 came about in September. A lot of you may not have the newer version of Chapter 9, and if you needed a resource for documentation and coding, the answer is the CPT. If you need a resource regarding Medicare billing of virtual communication services or things that we speak of, please do utilize these websites and do look for those updates because oftentimes I'm going to do my best to answer any questions you have, but I'm always going to do my best to tell you where that information is found so that you can prove it to others and track it. If there are those of you that are maybe a bit more new to FQHCs or the billing for community health centers, I highly recommend you go get this link here real quick, and then I'll jump into the E&M portion. But again, any information that you took from your previous career in private practice or just a regular traditional fee-for-service office, a lot of folks that get to community health centers and they start noticing that the billing is different. We don't just bill fee-for-service. We bill, obviously, to Medicare based on our prospective payment system. And this document will be a good one to help and identify for people what information they need to change a couple things in their mind because I've often heard it called very wackadoodle. Some of the guidelines are very, very different than what you deal with in private practice. We're going to run into scenarios where about halfway through the presentation, I talk about virtual communication services and some virtual visits. Now, not telehealth, but virtual visits are very different than telehealth. I'll do my best to kind of separate what they are, but I wanted to make sure that you know that coding and billing aren't the same. And, you can pick these. I'm not going to read all of these to you. I include some of these slides so that you can get links to various Medicare carriers and get an understanding of the true difference in coding and billing. So you're going to have to continue to establish processes by which you determine, is your provider going to just tell you what they did based on the definition in the CPT? Or does your provider have to remember, hey, wait a minute, now we're going to use code G2010 or G2012 that comes in that wonderful HCPCS Level 2 code book for commercial insurance when you're reporting virtual communication services. But Medicare says, don't use those codes. We have our own code for you to use, which is G0071. So there's an example where a commercial insurance might want the G2010 code, but Medicare wants G0071. Sometimes if you're not getting paid by an insurance company with one, I want to make sure that you're aware of additional options and that you do not bill all patients the same because you're getting an encounter rate from some, you're getting fee-for-service from others, and if you're a member of an accountable care organization, for example, maybe that uses a patient portal, you may be getting paid per member per month, where your payments actually might change based on diagnosis code. So let's tailor it back here to E&M, but some of those introductory issues are important. Please note here, just of course on this slide, that the CPT gets updated more than once a year. Notice here that the vaccine supply codes can be updated at a minimum of twice a year. But in addition to getting the AMA CPT, you're going to have to make sure you have a current copy of the 2021 HCPCS Level 2 code book to get some of those options that you may need to use for billing. Of course, we're not going to spend too much time on the ICD-10 there, but just confirming these are the resources we're using. So the E&M codes in the CPT are the only codes in the CPT that are numerically out of order. So notice in this particular case that there are examples. I got to click on something over here, please. There are examples about 11 to 12 pages of information that precede the first code in your CPT. That's the information that has received the most updates since 1992. If there are questions about how and when you can report E&M services on the same day as surgeries, et cetera, we may need to take care of that outside here. But there are significant changes not only to those dozen or so pages that precede each of the codes, but there are actually a lot of updates inside the definitions of several codes in 2021, and again, in the parenthetical statements and the little items below the codes that unless you have the AMA CPT, you will not see, because the AMA licenses the CPT codes to software vendors and the definitions to different software vendors and encoder software, but they don't license those notes to anybody. So please have that with you. Now, background on the CPT, not that huge of an issue, but I did mention something called the Patients Over Paperwork Initiative, and I would like you to maybe look at this when you have a chance, because there were some potential issues brought up in this Patients Over Paperwork Initiative that I'd like to give you kind of the background that came from, for at least one more day, I should say, Seema Verna, the administrator of CMS, that really explains, let me make that a little bit larger, that really explains some of the background, and that there were long overdue changes that were needed in order to help providers more accurately capture the services they were doing. Now, notice they've been hinting that all the way back to 2019 that these guidelines would be changed, but some of the guidelines or some of the proposed things that we heard about even through mid-year last year didn't happen. So please take this link with a grain of salt, if I can say that. But there is an idea out there that they were trying to implement, even for fee-for-service providers, a single payment rate for levels 2, 3, and 4, and a single payment rate for level 5. Even if that goes into effect, let's say sometime during 2021, it will not impact our need to properly pick the correct code, because whether we get do a level 2 visit or a level 5 visit, quote unquote, we get paid the same. But I urge community health centers to be comfortable and confident reporting higher levels of service if you have the documentation present, because for many, many years, we just kind of threw codes down knowing we'd get our PPS rate, but that rate may not have kept up with the actual increase in your costs. So by showing that we are providing a lot of high-level work here, by not limiting yourself to lower levels of visits, I should say, the effort to lower provider burnout and encourage more time to be spent with patient, time being a key issue updated in 2021, I wanted to give you some of that background. But when I've taught, and as I mentioned, that's I've spent over 50% of my life teaching this. The second item here that we'll just briefly talk about actually ends up being one of the most important aha moments that clinical providers have when they attend our training. And I know that you're using an electronic health record there, but I just kind of picture an old medical record. We know that the patients are looking at the last couple days of service before they go into the room with the patient. You're going back to look at the labs. You're looking at the master problem list. Your providers are treating the patient holistically, but they're looking at information from many, many different areas in your medical record. But there is one vital statement that we still need to keep in mind that will not change for 2021, and that is that each day's documentation must be able to totally stand on its own to support documentation requirements. Now, this is going to have a little subtle shift based on the 2021 guidelines that both the AMA and CMS have approved there. But the goal here is to minimize the need to rewrite additional information from a visit 2 days ago. And we need to make sure, however, that the templates that we're using for our providers get updated to reflect these changes, that your encounter forms get updated to reflect the changes. And we're going to have to train providers how to put down on today's note what other information they looked at from other areas without having to rewrite it. And when we get to the distinction between time-based E&M and medical decision-making based E&M, we'll bring this concept up again. One of the other preliminary slides I wanted to put in here is over the 26 years I've done this, these become a lot of the common questions. And the idea there is we hope that your providers are able to complete their documentation within 24 to 48 hours, but depending upon the conditions of participation with various insurance companies or any state rules that you have, please be conscious of the need, starting in 2021, to give your providers enough time during the day, if at all possible, to document today, because there's a piece of the change that was only 5 words in the CPT, 5 or 6 words in the CPT, that will, not even potentially, will almost assuredly lower a level of service if your providers aren't able to complete the note on that date. Now, we understand that deals with scheduling and patients asking for things that we didn't expect, et cetera. But when we talk about time-based E&M guidelines, and that's obviously the big secret, that we now in 2021 are going to be able to not worry about the history and the exam guidelines that we've focused on so heavily for many, many years. But there's a secret here, or a trick, I should say. When we get to the E&M guidelines that now are going to be based on time or medical decision-making, folks, it is only for office or outpatient services, all right? So it's only for office or outpatient services. All of those guidelines you may know about with the level of history requiring you to carefully document history of present illness, review of systems, and past family and social history. For those of you that know the 30-something pages of Medicare guidelines about the 1995 or the 1998 guidelines, yes, they go away for 2021, but only for office or outpatient visits. If you see patients in an inpatient setting or in a nursing facility, you still must follow those guidelines we've been dealing with for a long time. So let's get back into and highlight, before we get into that, because that's what we're going to end with, some updates related to distant site telehealth. And I want to compare telehealth visits, okay, and I'll hold my phone up when I'm talking about telehealth visits, versus virtual communication services and what they call a store and forward visit or an online digital evaluation and management service. So the positive change that we got mid last year is that we are now able to, as you well know, we're able to be a distant site providing telehealth, meaning the patient is distant from us. The patient is not face-to-face in an authorized location like your office, but they're at their house and your providers are performing telehealth visits. Well, that update has been extended through the end of the public health emergency, and all signs point to that continuing on, but it's something to be careful of. Now, although there's a modifier 95 that is used according to pure coding guidelines, you don't need modifier 95 when reporting code G2025 for distant site telehealth that you're going to get about $92 for. But there's some really interesting issues here that we need to dive into deeper, and that is things like audio and or visual needs when reporting telehealth visits. So where the new code G2025 is specific to community health centers, specific to you, specific to rural health clinics, there's still the opportunity, if your patients are coming in your office, to report a Q code I'll share with you on the next slide to get the $32 if the patient's in your office and you wheel the audio and video cart in. There's a Q3014 code that is not going to generate your PPS rate. It's not going to generate this $92 telehealth rate, but it's going to get you about $32 for bringing in that audio and visual cart. But interestingly enough, look at this. Medicare not only allowed us to perform distant site telehealth and getting a good flat rate of $92 there, but they also expanded the list of services. We go here. They also expanded the list of services that a community health center can report using distant site telehealth to include codes that we've never been able to bill Medicare for. Okay, now that's a little minor mess up on my behalf. I'll make a little note to make sure to get that updated before you guys get the slide, because for 2020, code 99201 and code 99211 are on the distant site telehealth list. Folks, we've never been able to report 99211 in the office, but according to the CMS current covered telehealth list, you may, if clinically appropriate, if operating within the scope of your licensure, report a 99211. We've never been able to get paid, I shouldn't say never, but for decades, we have not been authorized to bill Medicare for group therapy. Well, during the public health emergency, because Medicare is paying other providers for group therapy, let's just say group psychotherapy for a moment, or even group diabetic education, you've got an opportunity here to continue to relieve the strain of the in-person visits on your office to even get paid for group therapy services during the public health emergency. The reason I put a little X there over 99201 is because it was deleted for 2021, and I think that was a very positive move there. So we talked briefly about the G2025, that you probably don't need modifier 95 on a Medicare claim. You definitely don't. But be prepared if you're getting denied for telehealth with commercial insurance companies. They may need to see either modifier 95 and or the new place of service code that came out a couple of years ago, which is place of service 2. So as you've noticed, for those of you that deal with insurance companies, you can call the insurance company and say, hey, why aren't you paying me for this service? Did you want modifier 95? Do you need me to add place of service 02, or do I need to add both? And what do they usually say? We're not allowed to give you billing advice. So I hope that this session provides you with some options and alternatives to be aware of. But what I do want to talk about here for a moment is the distinction between telehealth visits, and we're going to make a little borderline here between the virtual check-in services. Now, you heard me mention a pure virtual check-in. That's going to be HCPCS code G2012, or what you may hear of called a store and forward visit, where the patient has initiated contact, and both of these services require that the patient initiates contact. The background resource and reference document for this was back there in Chapter 9 and or Chapter 13 of the CMS Benefits and Claims Manual. So everything I'm mentioning here, you don't have to take notes. Go look at those updates, and you'll be able to identify the kind of the store and forward technique where the patient uploads audio so the provider can hear their voice, or or hear how they're breathing, or you uploaded an image of their hurt elbow and the provider asks the patient to send one of those every Wednesday or every day for a week to prevent or limit the need for an in-person visit. Well, there we go. Coding says use G2010 or G2012 for that, but Medicare has their own code, G0071, that we need to use there. At the bottom of this slide, you'll notice that the reimbursement that Medicare gives us is not always via the PPS system. I mentioned the Q code for originating site telehealth where the patient's in your office, pays a flat fee of around $32. These services, G2012, G2010, that are reported using G0071 to Medicare used to pay at about $13.50, but when the AMA added, the CPT online digital E&M codes, and I think it's 99421 to 99423 that we will have on a slide for you, and they will be sending the slides afterwards. Medicare pays us as an FQHC the average of what they pay all other fee-for-service providers in the country, and that was about $13.50. But the moment they added the CPT online digital E&M visits, it doubled the reimbursement. So I'm not going to be able to click on every link here, but I will urge you to open each of these up. When you get the PDF, they will be live and active hyperlinks for you to go ahead and pull from. Reporting telehealth to Medicare, wanted to make sure to get you the revenue code there and the HCPCS code. And they say modifier 95 is optional, folks, but the definition of code G2025 states distant site telehealth. So my personal recommendation would be to avoid adding modifier 95 on that code for Medicare, but to be aware of it as an option for Medicare Advantage or some of your commercial plans. So if you need to access some more frequently asked questions, I've made sure to pull two out here for you. One, our Medicare's COVID-19 FAQs, another's coming from the AMA. And for those that maybe did not join us at the very beginning, Philip graciously shared with us NAC's COVID-19, kind of a landing page that had close to 10 additional links. And we may be able to show that to you at the end for those that weren't able to join at the very beginning or weren't able to kind of see that. So other general items that I kind of pulled out of those FAQs is that during the public health emergency, they relaxed the supervision requirements for your PAs and nurse practitioners and midwives in terms of how often they need to be available. Here's that Q code I mentioned about the $32 payment there. And what I'd like you to do is go to, when you get the chance, or if you have not looked at it recently, go look at this Medicare covered telehealth list. I thought that would just open it up here, but I want to show you something very interesting here. And of course, it's going to require me to go through all of this stuff. What I want you to look at when we get there, here we are, is that they added a column to this telehealth covered service list during the, well, two things. One is they added it and they'll tell you whether or not a specific code is only a, let's see if I can make this a little bit larger, if they're adding it as just temporary during the public health emergency, like this code for neonatal care, or look at this, services, and this is just in a more recently updated version that was updated 5 days ago. So if you have the older telehealth list, make sure you notice this thing was just updated January 14th, and that many codes down here, are only temporarily during the public health emergency, but some of them, look at this, home visits covered for the entire year within which the public health emergency ends. So may have been some recent updates there you need to be aware of, but look over here. Somebody's aunt or grandmother may not have Skype or FaceTime or any of the phones that provide, or tablets that have audio and video. So look at this requirement, this option over here. can the audio-only interactions meet our requirements? Folks, there are tons of codes that can be provided via audio only. Please make sure you recall that these are standard traditional visits put onto your schedule, not a patient calling in for a virtual check-in where they want to speak with the doc. That's the virtual communication services. So wanted to make that brief distinction there. Thank you for letting me go scan that. And again, for those taking notes, that's kind of what you would have seen there. And this is an example on slide on this slide where you notice one of the interesting issues. That is, there are a lot of codes on there that you can get paid for as of right now today that we've never been paid for or never been eligible to bill as a community health center. I hope that that is a positive news. If you did not know that already, you'll be able to go back to basically July and identify some of those codes that you wanted to report, but you were just going to put it on the cost report, and you may have the opportunity to go back and back bill a significant issue. But it is correct, and it is absolutely awkward, it is absolutely odd, but there is one list for all Medicare providers. I know it feels odd to say a 99211 does not have a qualified provider. A nurse is not a qualifying provider. We are during and we are here for a temporary addition. So go find that temporary addition and obviously process claims as needed based on the guidance that's given back there. So we have seen many be able to report things like group therapy that were added as a temporary addition. So some of the details behind virtual communication services there, the hyperlinks are provided both to Chapter 9, Section 240, and the virtual check-ins also have a time restriction just like the new E&M codes will for face-to-face visits, and that is the virtual check-in must be, the contact must be initiated by the patient for over 5 minutes, and here's the kicker. For a condition unrelated to recent visits that do not result in an immediate visit. So again, I know this 99211 sounded odd, and you cannot report a 99211 to get your PPS rate, but you can report it for distant site telehealth. I'm not saying to do it. A lot of providers are hesitant to allow the 99211. But when a patient calls and checks in, we've got to support the idea that before we bill G0071 for this virtual communication service, that it was unrelated to a visit that was done in the previous week, and that encounter does not turn into a face-to-face visit basically the next day or at the next available appointment time. So here's the interesting issue to think about that from an operational perspective. The concept here is that when you're reporting services to Medicare, it's going out on the CMS 1450 form. You might know it as the 837I form, the electronic version, or many of my veterans out there, you might call it the old UB form. Well, recall that when you submit claims on that 1450 form, you do not link the diagnosis codes to each individual CPT and or HCPCS code like you always do on the 1500 form, the regular old fee-for-service claims that you may be submitting. So one of the things we've noticed is because there are over a dozen lines on that claim form for a bunch of different diagnoses, we've noticed that many providers with no ill intention, trying to do their best, puts every single darn diagnosis on that claim because they may have mistaken the idea of, hey, your EHR might require you to update the master problem list for every patient at every visit. But remember, one of the first slides I put up there was that each day's documentation must be able to totally stand on its own to support documentation requirements. So think about the idea that you may have a patient that has 8 different diagnoses, but they only came in today because of a cut on their arm. Well, folks, the only diagnosis that would go on that claim would be the laceration on the arm, and any of those 8 that was documented on today's note as affecting that care. If the patient has a communicable blood disease or is at high risk for infections, then yes, those diagnoses also go on your regular office visits. But if there is an unintentional or an accidental over-reporting of too many diagnoses on every claim, it's sure going to make getting paid that 25-ish bucks for G0071 difficult, because if you submit G0071, okay, we'll look at these items here, okay, just kind of giving you another view at it. If you had put all 8 of those diagnoses from Monday's visit on the claim, virtual communication services are going to get denied. So there's not a very easy way that I've seen yet for medical records documentation templates when your providers are documenting that they performed a non-face-to-face communication technology-based, notice the keywords here, for an established patient that lasted over 5 minutes, not related to a visit in the past 7 days, and does not result in an appointment in the next 24 hours or appointment slot. So, there's a lot more to look at. Go look at section 240 that I initiated on the other slide, and recall that commercial insurance probably wants G2012, okay, while Medicare is going to want the G0071. I'd like you to think of G0071 as an overarching umbrella code that contains virtual communication services, as well as what we kind of hinted at earlier is called the store and forward technique. Oftentimes, accountable care organizations have a patient portal where they can send you information or pictures or video. I even heard, I think I heard them correctly, that they have their patients taking oral medications for medication-assisted treatment. They're actually asking them to send a video of them taking their medications. But a little bit of a tricky issue there, but the same concept applies. If your providers maybe have a virtual exam room schedule that's on their schedule, that maybe they're off between 12 o'clock and 2 o'clock. They don't have office hours from 12 o'clock to 2 o'clock, but they go to their desk and they see, hey, wait a minute, I've got some patients that have uploaded images, uploaded audio, uploaded video into the patient portal. If I spend, and as long as I spend over that 5 minutes reviewing this information, key is that I've got to view that information within 24 hours of when the patient sends the pictures and video. So as opposed to just kind of emails and things like that, it should be something that triggers you. Make a virtual exam room, and then you have the same issues related to over-diagnosing patients on their face-to-face visits by listing every diagnosis they have instead of only listing the diagnoses that were documented on that date of service as affecting care. So in this particular issue, you see those, and then I promised to give you the codes several months after G0071 was created, when Medicare doubled the reimbursement to us to 25 bucks by adding a CPT digital E&M code. So again, to those who felt a little reticent of reporting a service by a, quote, non-qualifying provider for that 99211, please remember that community health centers have really interesting billing rules, and that a dietitian can get paid when performing diabetes self-management training, and they're not actually an authorized provider either. So there are exceptions to these rules, and there are even more during the public health emergency, but please keep track of all of these items. Now, one interesting thing to point out about these online CPT digital online E&M codes is that these codes, separate from a virtual check-in, separate from the store and forward technique, is based on the cumulative time spent during that 7-day period on whether 99421 was at 5 to 10 minutes, was it 11 to 20 minutes, or code 99423 for 21 or more minutes. And so balancing those guidelines off, by the way, with the over 1 page, I think it's a page and a quarter of, right around a page, in the CPT, as we described at the beginning, you have to have the CPT to find those notes, where they're going to help distinguish an online digital E&M visit, but they're all, for you and I in a community health center, going to be reported under the same umbrella code. But since we're not just billing Medicare, we want you to be aware of the options for the CPT online digital E&M codes, where there is a 20% patient coinsurance amount when reporting to that. So these slides are more on the diagnosis side for COVID, but Philip already gave us a couple good examples there. Let me take a look at the time. He already gave us a couple good examples of some more updated things here. And this was just to clarify and confirm that 99211 code is a non-qualifying visit for FQHCs when done face-to-face, but based on your medical office, your chief medical officer's opinion and or advice or work to be done. Remember, they don't limit community health centers for telehealth any differently than they do fee-for-service providers, and that does feel a little bit different. But it doesn't matter if you ever see a face-to-face patient with an RN, a 99211 would never be reported separately to Medicare unless done via telehealth. But if you're thinking about it again, folks, they don't know, they being Medicare, when you report G2025, they have no clue which of the codes on the CMS telehealth list they're paying you for. Now, I'm sure, they had a lot of work to do during the public health emergency, and I can't even imagine the difficulties in kicking up a program with a new code and new rules. Setting up that $92 payment was a really, really tricky issue. But there are no limits because you do not need to say necessarily which code you're reporting G2025. It could be anyone on that telehealth list. So you're not getting away with anything if it was a 99211. It is a unique opportunity only during the public health emergency. Let's get to the meat and potatoes here. I'd like to ask this. I can't see the chat box. I've kind of covered that up while I'm teaching, but I do like to ask people this question when I'm in a class, and I'm going to give John Burns, one of my dear friends and colleagues for 20 plus years, and coming up with this one. He says, how many E&M codes are there? And I think he got that from a gentleman named Frank Cohen, who's a really kind of an E&M statistician. And people, throw out a bunch of different numbers, and the answer is there's one. It's the right one. What is the right one for each encounter? Let's dive into what we need to deal with here. This isn't exactly the session to go into a deep dive background, but I believe you will likely see a change in your E&M utilization patterns this year for many of your providers. So the need to continue to do ongoing internal evaluation and management chart reviews, I think a minimum of 10 encounters a year, 20 encounters per year is probably a better number to give you a decent statistical sample. But when you get this down here, where's my mouse? Notice down here at the bottom, please. I wanted to give you yet another website, and this is for Medicare, where you can go look at the utilization patterns of a provider by completing this little spreadsheet here. You can see how it tracks, and they'll compare it to the national E&M utilization patterns. And you will be able to identify providers who are coding on average a bit lower or even a bit higher than their peers. Well, I'm not going to worry if I'm a little bit lower than my peers or a little higher than my peers. Heck, even if I'm much higher than my peers, because what if my peers aren't documenting and coding correctly? So the advantage to performing 2021 internal E&M audits to prepare for a potential audit would be extremely valuable in order to understand the variance of where your providers are. But based on what I'm talking, the people that I'm talking to and teaching virtually, I think you're going to see potential increases and appropriate increases in utilization this year. If Medicare sees that, it won't be a surprise whether they kick back the recovery audit contractors or continue to perform randomized or even targeted actual formal audits. We want you to be prepared and have an understanding of where that falls. Now, if you are going to find a provider whose utilization over the course of 2021 goes up or down by a specific percentage, we want to not only make sure that they have access to any ongoing training there, but if you're paying those providers based on their production, think about what that may do to salary going up or down. Now, it's going to be easy to maybe, or it may not be easy, but you may see an increase in utilization. Does that mean the corresponding increase in salary is appropriate or not? So managers, we want you to take this information with you if you're paying your providers based on what they code versus what you get paid for. Those are two different discussions. So we could probably do an hour just on that concept here. But for those that I know we have established veterans on the call and some folks that are new, the CPT definition of new versus established patients has only received one update to my knowledge in the past 10 years. And that is the AMA updated their definition about 10 years ago to consider the provider's specialty or subspecialty in terms of whether it's a new patient that hasn't received face-to-face services for 3 years, nor have they seen any other provider of that specialty in 3 years, then it would be a new patient. But as you well know, the definition of a new patient is not defined the same way in a community health center. So per Chapter 13 of the Medicare Policy Manual, a new patient is one who has not received any professional service from any provider within the FQHC organization or from any sites within the previous 3 years prior to the date of service. But as I understand it, we have to add something to that, because for those of you in a community health center that provide dental services, if that patient went to see a dental provider for a non-covered, let's assume Medicare now, I'm going to stick with Medicare, right? But if that patient went to see the dental for a cleaning, well, a cleaning is not a covered Medicare service. So the patient hasn't received a Medicare covered service from anybody within that organization within the previous 3 years. They still would be a new patient. But if they've seen family practice at any of your 6 locations, the first day they walk into this location, they're an established patient. But look for a really good FAQ document that confirms things where there are some little unique issues. So if I'm working in a private practice, for example, and I bring my patients with me to the FQHC, even though I have provided a face-to-face service, if nobody in our organization, even if you have 6 different locations in the state and 3 of them bill one Medicare carrier and 3 bill another Medicare carrier, doesn't matter. If your FQHC organization has seen that patient for a Medicare covered service in the previous 3 years, they are established. And then as I linked you to and pointed out some of this related stuff for using your kind of your 5 prime, whoops, let's go past this one. Going past your, to locate one of your 5 magical G codes there, you may actually have a rare scenario where you report on the same darn claim form a new patient visit and an established patient visit on the same Medicare patient on the same day. So the patient just moved into town. They have not seen anybody in any of the 6 locations we have spread out across the state. And they come in at 11 o'clock to established ongoing chronic care for hypertension, diabetes, and gout. Okay, then I'm going to have my G0466 code along with my 99213. And then at 1 o'clock that day, the patient now gets an established patient visit because they made an appointment for being treated for an existing mental or behavioral health issue. So we had a new patient at 11 o'clock, and at 1 o'clock, we have an established patient visit. The rarity of this is, notice, you can't report multiple E&M visits on the same patient to Medicare. The exception is a medical and a mental health encounter on the same day may be reported. Let's push towards the 2021 updates. I'm going to move past, let me do a little time check here, some of these preventive medicine services, but I'm sure some of you have heard some of these items. I'm just going to briefly mention that there were no significant changes to how preventive medicine services will be reported to Medicare or other carriers for 2021. All of these significant updates are going to be for only office or outpatient visits. But the real way that you're confirming the difference between a preventive medicine visit from the CPT that is not covered from one of your sick visits, or we call them problem-oriented visits, is that chief complaint. So please be conscious and aware, even though our focus in this session is not on preventive medicine, that the number one way you determine from the moment that patient presents in your facility, are we doing preventive medicine or a, quote, covered problem-oriented visit, is that chief complaint. But there are a lot of chief complaints that we discover in doing our audits that do not warrant a problem-oriented E&M code like 99214. For example, patient returns for, it says, patient presents for follow-up visit. You can't just have follow-up visit as a chief complaint for a problem-oriented visit, because remember, please, each date of service, as we said, must be able to stand on its own to support documentation requirements. And I know that's frustrating to providers because they say, look at this medical record. This patient's been here 5 times over the last 4 weeks. They're clearly sick. They need to be seen. We have to point out that each day has to stand on its own. So it needs to say patient returns for follow-up of, strained medial collateral ligament or something to that effect, or, age-related macular degeneration. That chief complaint must be added on each date of service. Otherwise, it may be easy to identify for Medicare that you got paid for something that was not reported correctly. So I did want to highlight this because I usually get a lot of questions. And again, please remember, I cannot see the chat box. But I do like to make sure people have access to this preventive services chart. It came out in August of 2016. Let me scroll down here. There's a lot of great information up there, but if you're interested in looking, can I make that a little larger? If you're interested in identifying information on the initial preventive physical exam or diabetes self-management training or medical nutrition therapy, the annual wellness visit, et cetera, this is a really good document that lets you know whether or not it's going to be paid under the PPS methodology and whether or not you're going to get the 34% increase in your PPS amount if you report new patient visits to Medicare, but it's not just the new patient visits, your established office or outpatient visits that raise that PPS amount 34%, but also the initial preventive physical exam and only the annual wellness visit. So that definition of new versus established is vital. You're going to get paid, when you're using, let me go back and show you the code that you were using there. When you report the initial preventive physical exam, let me get rid of some of the ink here, hopefully make it look a little bit easier. When you report, I didn't hit the right button there, I apologize. When you hit G0468, that code is going to generate, or should generate, a 34.16% increase, just like G0466 and G0469. I would urge somebody in your billing or accounts receivable or denials management or somebody on that tail end of the revenue cycle to go determine if Medicare, in fact, did increase the PPS rate to 34.16%, which would likely increase the patient's coinsurance amount And if they neglected to do so, please very politely make sure you're within the timely filing limits and the guidelines in terms of how you would appeal a claim, and go back and get that money, folks. I have had several facilities let me know following a class, they went back, noticed Medicare wasn't raising it by 34.16%. They were able to give the carrier the specific reference in Chapter 13 of the benefits, or Chapter 9 of the claims manual, and they got a pretty big check. So keep that in mind, folks, and let's finish this up with, here we go, the current framework in 2021 used to determine E&M coding levels. The CPT still lists history, exam, and decision-making as those key components. And it is not true that history and exam went away. We still have to document the history and exam we perform for all patients in all places of service. But the change in 2021 is that the history and the exam content is no longer being calculated to affect the level of service for an office or an outpatient visit. For years, we spent training providers on medical decision-making, but the CPT only gave you about a fifth of one page in the CPT to describe medical decision-making. But Medicare, many years ago, 94, 95, created multiple ways that you could train providers how to give themselves credit for what they're doing based on the amount and complexity of data they had to review, the risks of morbidity and mortality, and the nature of the presenting problem, etc. Those are what received a significant update. So be careful when you see me go like that and cross off exams that I'm only doing this for office or outpatient visits. And now in 2021, we are going to code office or outpatient visits based on medical decision-making or time. And I'd like to highlight those changes. So without going through the links there, you still may need the 95. And although I called them the 98 guidelines, they came out in 1997. You still are going to need those, all right, for your inpatient visits, nursing facility visits. No changes there. But for office and outpatient visits, it just says do it, what is it, a medically appropriate history or medically appropriate physical examination. So you will be able to select code based on time or medical decision-making in 2021. Notice it's only relevant to 99202 through 99215, folks. That's only 8 codes. But they happen to be 8 of the most common codes you're likely reporting to all insurance companies. As 99201 was deleted, it was kind of a throwaway code anyway. What we need to focus on is how they're defining time and how medical decision-making has been updated. In my mind, probably most important for all of this is we've had time listed in the definition for CPT codes for decades, but it was just one number. And it said something to the effect that, physicians and other appropriate healthcare personnel typically spend 10 minutes or 20 minutes with the patient. And the way the CPT from 1992 until December 31st of 2020 described time is that in an office and an outpatient setting, it was only the time spent face-to-face with the patient. Boom, that goes out of the water and is no longer correct when we're looking at how time is going to be defined in 2021. It's going to be defined as the total time spent on the date of the encounter. Okay? Look at this. And it includes non-face-to-face work done on that same day. And we really only use time if it was dominated by counseling and coordination of care. That also goes by the wayside. So I'm going to give you the full list here in 1 or 2 slides of what work from your providers and other authorized professionals are going to report are there. But remember, that's why I was telling you that I'm going to give it to you in the slides, but otherwise the full set of documentation is only found in the AMA's version of the CPT if you get your CPTs from another printer or publisher, it won't be there. But look at this one. Here's one little sample. Preparing to see the patient. The time you spent, not the nurse, but whoever's going to be reporting that service, preparing to see the patient. Remember earlier I said they might look at that health record and go back and look at the last couple dates of service. They might go look at the labs and update the master problem list and familiarize themselves with this patient or ask another provider who saw them last week something. That time is being or should be captured when reporting the total duration of time spent on the date of the encounter that is not only preparing to see the patient, but look at this. This was a bombshell to me. This was a bombshell to me. Documenting the clinical information in the electronic or other health record will likely or could increase the code you report if you're choosing time rather than medical decision-making. If you're using time rather than medical decision-making, it's not face-to-face like it was since 1992. It's preparing to see the patient and the time they spend on that date. Now, if your office and your malpractice and liability plan or whatever allows providers to go home and they have their dinner and they, are able to remotely access the EHR to complete their notes on that date, then the clock was ticking before I walked in the door. The clock was ticking while I was face-to-face, and the time I spend, if it's on that date, is also considered when reporting time. But as you'll see here, it's not one time associated with each code. It's a range of codes, okay? It's a range of codes. And so nothing really there at the top, confirming what I mentioned earlier there. So notice the traditional 15-minute appointment slot, which may or may not be reflective of the patient's needs, but let's just run with the traditional 15-minute appointment slot. If I only spent 10 minutes with the patient, 15 minutes with the patient, 19 minutes with the patient, unless medical decision-making is going to allow me to get to a higher code, I'm going to have a 99212. But let's say the time spent preparing to see the patient and the face-to-face visit was 18 or 19 minutes. So 99212, but wait a minute. The patient went home or, at the end of the day, spent 8 more minutes documenting in the medical record what just happened. We just moved to a higher level code. So you're going to see a need for some discussion about traditional new patient appointment slots, traditional established patient slots, and some of these codes, it may feel as though, well, geez, that feels to me like it's actually going to be dropping my level of service because, we always would tell providers, you can do a 99215. You can document the 99215 in 10 minutes. But for now, if you're using that, we have to follow the idea of the E&M services being based on a range of time. And here are those items that are included in the new definition of time. Before I show this, please remember that if you were thinking, well, geez, I thought I did a much higher level of service, but all told, everything together was, 18 minutes. I guess I've got a 99212. Nope. You still have the opportunity to report a different E&M code if you're not using time, but rather the updated definitions of medical decision-making. And I'm going to give you at least 3 different tools to look at, and then we'll be able to open up for questions very shortly. But here are the items that are there. Preparing to see the patient. And by the way, this is coming straight from page 8 of the AMA CPT under the Evaluation and Management Services Guidelines. For those familiar with the CPT, it's kind of those green pages that are before the actual definitions of the codes. Obtaining and or reviewing a separately obtained history. Obviously, the time you spend doing the medically appropriate exam, counseling and educating the patient and family members. So you're spending time talking to them about prognosis or risk factors or family expectations or diet or risks of non-compliance. The clock is still ticking. The clock is still running. That means that unlike for the previous 20-something years, if the provider broke face-to-face contact with the patient but went out to talk with a family member in the waiting room, the clock now in 2021 is still ticking and could have an impact on your final code choice. Even after the visit, you have to have the provider going in there and generating medications or tests or procedures to order. Even though that may not be face-to-face, the clock is ticking. Referring and communicating with other health professionals. The key here, as long as it's not already being separately reported, for example, with chronic care management or, principal care management there. Documenting the clinical information in the electronic health record to me was the big bombshell. Independently interpreting results, as long as you're not billing for that EKG interp already, not otherwise reported there. And then any care coordination, as long as you're not already using that time to meet your 20 minutes of chronic care management. So there's got to be some balance if you have an ongoing chronic care management process. If those chronic care management services happen when the patient leaves, you have to pick kind of one or the other. It's just the shortest way to say it. So for those of you that have gone for years with the how many items for history for, and I can't highlight the non there at the top, but you may have seen these location, quality, severity, duration, timing, context, associated signs and symptoms, and modifying factors where they count the number of systems that are being reviewed. That you're looking at how many items from past family and social history, they don't go away. They still exist for non-officer outpatient visits, and we actually have a 6-hour class just on teaching that stuff. I'm going to finish up here in about 4 minutes and open up for questions. So we just included these as a reminder there, and the quick little reminders there, especially this one, if you're unable to obtain a history because the patient is non-communicative, there's a language issue that you couldn't resolve with a translator, or they had a concussion, or they are a, quote, poor historian of their care, please make sure to point out why if you were unable to obtain that history. And if it happens to be an inpatient encounter, you would be able to actually take credit for a comprehensive history. But same ideas here for those of you that are familiar with the wonderfully fun, I hope you can sense the sarcasm through the internet, exam guidelines, whether they're the 1995 organ system-based, body area and organ-based guidelines versus the 40-something pages of these. It goes away for 2021 for our officer outpatient codes. And make sure you're, of course, still documenting it, but whether it's a high or low history or a high or low exam is not going to affect your office visits per se in 2021. The framework before 2021 for medical decision-making used a little score sheet that Medicare came up with in the mid-90s. I started in this industry in November of 94, and as far as I remember, it goes all the way back to that point, where we actually get different points calculated based on whether a problem is worsening or is it stable, etc. Although that says pre-2021 framework, it still applies to inpatient encounters. And these phrases, the number of diagnosis or management options, amount and complexity of data to be reviewed, where we get points for ordering or performing certain tests. And then this table of risk, where you likely have received training on this in terms of how you would select, various options within medical decision-making. Each one of these have received pretty sound updates, and I want to share with you where those are as far as the slight update to the way each of these is being described. Very, very slight update in terms of the title, more of a major update when you're trying to determine level of service. There are words, there's 3 or 4 pages in the CPT where I applaud them for confirming the need to create definitions of some of the words that may be a little tricky, or they had been up for interpretation in the past. So in addition to educating your providers on the time and what's included on the date of service, that they can use time or medical decision making, this would be a good opportunity on pages 12 through 15 of the E&M guidelines just to see if there's a discussion on what some of these items may mean. Now, I realize the screen just got tiny, but I promised to give you, let me do a little time check here. I promised to give you about 3 or 4 ways of looking at this. Each of those 3 areas of medical decision making have been given their specific guidelines here. Number and complexity of data, number and complexity of problems addressed in the center. All right, it's the amount and complexity of data to be reviewed and analyzed they've added. And then over here, they've got the risk of complications and or morbidity or mortality there. The main item to look at, and I believe Philip mentioned that he's going to be sending the slides out at the end of the session, but I do want you to know the way you're going to determine medical decision making for officer outpatient visits in 2021 is based on the 2 highest of these 3 areas. So let me get rid of the ink here and let me give you another option on how you might want to look at that. But the quick idea is, let's say I knew, forget about the time. We had a 15-minute visit with the patient, soup to nuts, beginning to end, 15 minutes. So based on what we looked at about 7 slides ago, you're thinking 99212 that said anywhere from 10 to 19 minutes. But wait a minute. Excuse me. Let's say we have 2 or more stable chronic illnesses. How common is that in the community health center? I pose it's pretty darn common. Even though we maybe only have 1 item up here, what happens if we do prescription drug management? Well, remember, I get my 2 highest. Well, I don't have any marks across from high, so I can't report a 99215, but I met 2 items for this code. And although the time option would have gotten me to a 99212, by going through and studying this in more detail, matching your EHR templates to some of these opportunities, or letting your providers be providers, document, and then a coder or a qualified or a certified biller comes in to look at this. In that case, folks, I've got a 99204 or a 99214. That is also unique to the 2021 changes, that a 99204 and a 99214 can be pulled from the same documentation guidelines. It was never like that from 1992 until the end of last year. Now, right here at the bottom, I know that's a very long way to do it, so what I did want to create is a slide for each one of these 3 areas, and I want to point out a couple little interesting items here. So remember, you have to have 2 of the 3 areas of decision making to get there. So just because you had the 2 or more stable chronic illnesses didn't mean I got to report the 99204. This is just that first column. But heck, I bet you might have scenarios where there's a patient that's going to lose their eyesight or lose their foot due to diabetic neuropathy or diabetic retinopathy, etc. Or a patient that has an acute or chronic illness that poses a threat to life or bodily function. I'm halfway home theoretically to a 99205 or 15. I believe that it's going to be that first column represented by this slide and more of the 3rd column in terms of the amount of risk that will likely drive your E&M codes if you're not using the option of time. Because of things like, going through and looking at this, this is the one that's a little bit complicated in terms of, in order to get to this moderate category, I've got to at least have 1 item in each of the following categories. So I must have reviewed a prior note from a source, I must have independently performed an interpretation, and I must have discussed that with an outside provider. Those are not the ones that I think are going to probably drive a lot of your reimbursement. Rather, it's the amount and complexity of the problems to be reviewed and analyzed, and then the risk of complications and or morbidity or mortality. So prescription drug management is the one that you end up hearing the most of. So be sure that even if you are continuing the current medications as previously, ordered, make sure that's being put into the note proper. Obviously, it'll be in the note if we order new prescriptions, if we cancel a prescription, or if we adjust a prescription. But in order to make sure we're documenting our medical decision-making carefully along with these guidelines, the prescription drug management that continues current meds as ordered would be an appropriate phrase to help support or get you halfway home, even though a 99214 or whichever code is there. But for those of you that are aware of the diagnosis codes, they're Z codes that are never used as a primary diagnosis on a billing claim, but those social determinants of health, obviously they're going to become more and more common, whether you're performing medication-assisted treatment or you're just trying to match your patient up with local or state programs that will help overcome barriers to healthcare, such as lack of routine housing or transportation or these environmental factors that public health so desperately needs us to provide as supplemental data in order to really serve public health goals that go far beyond in a different direction than for you and I to get paid. So the inclusion of, as I understand this, if there's a diagnosis or treatment that's significantly limited by a social determinants of health, that better show up as a supplemental Z code. But even if there's not prescription drug management, I think that the traditional 15-minute visit that would have been a 99212 if you use time, I'm not saying bill everything a level 4 visit for goodness sake, but just using this as a sample would provide an opportunity for getting and reporting E&M codes that are probably more reflective of the work that you've been doing for many years, but because of this idea of I needed a bunch of history and a bunch of exam to support it has gone away. I hope that this information can help out. So here's another kind of a different way of looking at each of those three columns. I'm going to look at my time here. I had promised to end at 3:15 for questions. I'm about 6 minutes over. My name still is Gary Lucas, serve as Vice President of Education. I want to thank Philip and Brendan and Olivia, and obviously want to thank Jervine Williams and Ray Jorgensen, folks that I've taught with here at NAC. When we talk about the medication-assisted treatment work here next week, we're going to be referencing an absolutely slam dunk, wonderful document that was created by NAC and their educational partner, Ms. Sulzberger, who created just flat out one of the best documentation training, little booklets on documentation and code capture for medication-assisted treatment. So expect to see that next week. If you already can go on NAC's website and locate that document, making sure to peek if there's been any coding updates, in which case I don't believe there has. We look forward to seeing you next week. As I get ready to turn this back over to Philip for questions and comments, we may not be able to get to them all today, but I'd like you to feel comfortable reaching out to me and knowing that, let me see, I'm going to hit the click stop sharing button. I don't even know how many people we had. I haven't, oh my goodness, 392. So Philip, I'm handing it back over to you. Oh, there's a lot of questions. I defer to your recommendations, sir, on how we should handle those.
Awesome. Thank you so much, Gary Lucas with ArchPro Coding. A lot of great information. As you said, we have a little bit over 35 questions that we received, and I think roughly over 400 participants. So thanks everyone for sticking in with us. We are going to try to get in as much questions as possible before our time runs out together. But I wanted to first start off. We had got a comment from Jervine. I don't believe she's on the call as of right now. But wanted to provide some clarity. And of course, Gary, if you have any additional feedback, feel free to provide it. But she was saying that she wanted to clarify the information about charging for nurse visits. Says you cannot get paid the PPS rate for a 99211.
If done face-to-face, at the facility, but rather for telehealth. I want to look at it because I have not seen one sentence. Now, that doesn't mean it doesn't exist, that states that it may not be reported via distant site telehealth using code G2025. I'm not saying you're getting away with anything, but when you report distant site telehealth, you're also likely not having to report the actual code that you provided. So they don't know if it's a 99213, a 99214, a covered therapy visit, or a 99211. I will look back into that because I can understand and appreciate how odd that feels. But when Medicare said, hey, rural health clinics and FQHCs, you still can't do this stuff in person. You can't report a 99211. You can't report group therapy, but you can report the same services that we pay other Medicare providers for during the public health emergency. So the difference is face-to-face at the clinic versus via telehealth. I'll make sure to follow up on that, but I have not seen
Definitely.
in Medicare MedLearn Matters, what is it, 20016, that was updated to do that. But it is worth looking into, and I'll make sure to pull that up.
Definitely. Thank you. So we're going to go ahead and dive into the wealth of questions we received. So it says, have you heard of claims not being paid using the G2025?
Oh,
I have claims going back to August that Medicare processed with CO45 for the entire price of the visit.
Well, CO's contractual obligation, I don't remember the 45, but yes, there have been, when they created the G2025 code, my words, and I don't want to speak negatively of the folks that had to make these very hard decisions, carriers are not aware of how to do this, and a lot of carriers weren't aware of how to generate that $92 payment. A lot of them were paying the PPS rate and then had to go back and take that money back. Rural health clinics had the opposite problem. Some of them were getting less than the $92, and then as of like August, Medicare was supposed to go back and do it. So yes, there have been claim denials, but I'd want to be careful in overgeneralizing to say it's not covered. It's absolutely a covered service that should be generating that, and as long as it's one of the codes on that list, you should be fine. But if there's a specific service, feel free to reach out to me and look at it. But yes, carriers have had an issue because they get their data files at the beginning of the year to pay. There are periodic updates that happen on a normal year, but they're given 2 or 3, 4 months to make those internal changes in their claim systems. They clearly didn't have that full opportunity this time.
Thank you. So this question also came in. It says, can FQHCs bill for COVID-19 testing?
I don't know why they would be restricted from it. But again, now when you're talking about, did you say coding or billing?
Bill, just says specifically bill.
Well, sure. The CS modifier, I mean, they created a lot of unique administration codes and vaccine product codes that look different than a lot of the traditional 8 series codes that we use for labs. But one of the links, Philip, on your thing where your COVID-19 FAQs were that you had, should be there. I mean, yes, you should be able to code and bill for it, absolutely. Now, the key here, again, is if you're doing the service. If you're sending that lab service to a third-party lab or a reference lab, then they're going to do the billing. So, but there is no restriction that FQHCs can't report COVID-19 testing. No. I mean, now, whether you can do it in the parking lot versus in the office, if you're doing it versus sending it out, there could be 9 reasons that it may get denied, but yeah, no overall restriction.
Awesome. All right, working through it. It says, I recently called Medicare because we were not getting paid for the Q3014 and the telehealth visit on the same day. I was told they will not pay for both on the same day.
That's correct. The Q3014 is only used when the patient is physically present in your office, but that, you can't bill as both the distant site and originating site in telehealth at the same time, I don't think. I think that could be the issue. So in the question, I'm not sure if the other visit that was being reported there, you're supposed to report section 45, whatever it is of chapter 13, basically one encounter. If everything done medical, I don't care if they saw 4 providers on that same day for medical, there's 1 medical visit billed to Medicare. The exception would be if you had a medical visit and a mental health visit, or it was a visit where the patient came to your facility, left the facility, and had to return on the same day for separate evaluation and additional diagnosis or treatment. So the nuances of some of these understandably short questions, because there's only a little room to type it in, is there. It's what I do for a living. If whoever had that question wants to set up a quick little time with me and we can chat over the options. But I would not expect to report an office visit from doctor number 1 and then put the patients in another exam room, wheel in the cart and get paid for the Q3014. That does sound like Medicare is not going to pay you for both for those. Medicaid may. It depends on what their conditions of participation are.
All right. Thank you so much. It looks like we are right at time, everyone. I did go ahead and make a copy of all the questions that we received, so I'll make sure to get it over to Gary. But if you do have more specific questions, he did list his email address. We can get those answered there, but you can also send them my way, and I'll make sure to get them addressed as well. So I want to just sign off by just saying that we will make sure to send you a copy of today's presentation in addition to that blank CEU certificate for your credits. And Gary, was there any last instructions on that certificate you wanted to add for me?
Oh, yeah. The CEU certificate is for 2 hours, but if you're reporting to AHIMA or AAPC or any other certifying body, as always, since you are self-reporting, please only include the actual time that you participated in the training. In this case would be 1.5 hours. If you ever needed to justify the additional 30 minutes, go print those links out and do a little bit of that extra work. But it is required when you're self-reporting to do the actual number of hours, and the CEU certificate is for 2, but we did 1.5. So thank you for the reminder.
Yeah, perfect. And I'll make sure to include that in the send out email with the certificate as well. So once again, thank you all, everyone, for attending. I hope you all have a great rest of your week, and we hope to see you all next week for part 2. So take care.